morning. I'm Samhita Madan Mohan. I'm from Summerfield in Guilford County, and I'm sponsored by Senator Phil Berger.
Good morning. My name is Avni Patil. I'm from Charlotte, Mecklenburg County, and my sponsor is Senator Salvador.
Good morning. My name is Beckham Sharp. I am from Lenoir in Caldwell County, and my sponsor is Senator Ralph Hayes.
Good morning, everyone. My name is James Willis. I'm from Southern Pines from Moore County, and I'm sponsored by Senator Tom McInnes.
Good morning. My name is Grant Sabatis. I am from Bailey, which is in Nash County, and I am sponsored by Senator Moffitt.
Good morning, everybody. My name is John Cook. I'm from Conover in Catawba County, and my sponsor is Senator Settle.
Thank you. We enjoy you being here. I'm going to give you homework. Just because you're up here, you still need to be getting homework. So at the end of this committee meeting, I want you to find one of these senators up here and ask them a question. That's your homework, okay? So pick out who you're going to. Don't everybody go to Ralph Hayes, but look around. All these smiling faces here have a lot of knowledge, and I want you to ask them a question. Do you understand your homework? There will be a test later, so be prepared. We're glad you all are here, and I want to recognize our Sergeant-at-Arms who do a fantastic job of making sure that we get set up for these rooms, everything gets handled, people get in and out safely. And raise your hand when I call your name. Gary Bridges, Keith Whitfield, Mike Harris, Dwight Green, and Mike Norton. So thank you all. And then I have some instructions. We have a big meeting after this meeting. So when we conclude, and this is going to be pretty fast today, everybody go out the side doors. Don't go out the two doors in the back. Go out at one of these side doors, okay? Everybody got it? They'll make sure that we all do what we're supposed to do. As I said, we have two PCSs we're going to hear today. The first one is House Bill 390, and our co-chair, Senator Sari, is going to be presenting that. Senator?
Thank you, Mr. Chair. It's been a few months. This is a PCS.
It's a PCS for discussion only.
Okay, perfect. Thank you. This is a PCS to House Bill 390. You'll see this. The proposed committee substitute does a couple things, and I do want to clarify that this is only with respect to our application to our Medicaid programs only. The first is that it addresses our coding standards. Right now, those are the codes that various providers use when submitting claims to insurers or to our PHPs within the Medicaid program. It requires that the providers and the PHPs adopt a national standard for submitting that. There are national standards. CMS has a national correct coding initiative that helps states reduce improper payments in Medicaid by promoting consistent coding and billing practices. This will cut down on error, it will cut down on waste, it will cut down on potential confusion, especially when it comes to our payment rate, which we're seeing is becoming more and more important as a result of the changes from HR 1. The second thing that it does is it directs site of service it directs inpatient hospital lab services to outpatient settings where appropriate. Site of service is a big issue. I think we've seen some articles in the Wall Street Journal recently where we've seen some disparate pricing impacts as a result of things being forced into hospitals versus allowing people to look at ambulatory surgery centers, outpatient laboratory settings that might be more cost efficient, sometimes even more convenient to the patients where there's a particular need for it. We've seen that being pushed already in our House Bill 696 conference report, where the department is required to look at a plan for site of service and site neutral payments. This looks at it for lab services specifically. The last part of this bill, you'll see this in section 1B, requires the provides the ability for the PHPs to receive itemized billing statements for certain procedures that are done. You'll see it requires itemized billing for inpatient hospital outlier claims that are greater than $250,000 or more than 2 standard deviations from the median claim amount of the applicable billing code. I've been told, and don't ask me to define what a standard deviation is. I'm not a statistician. I think Senator Hayes could probably talk about that. But for different billing codes, there is a median price point. $250,000 makes sense in some contexts, might not make sense in other contexts. This provides some flexibilities where a PHP can obtain a bill, look at the invoice, make sure they're being charged for what's only appropriate for that particular procedure, have more data. Right now, you as a patient can get it, but this provides the PHPs who are charged with managing our Medicaid program with also having access to that same information. Again, common sense provision. I think this helps ultimately with making sure that we're being responsible stewards of our taxpayer dollars, and that the procedures being done are those which the patient needs. I'm glad to take any questions. Thank you, Mr. Chair.
Thank you, Senator. And now open the floor for questions. Senator Mayfield.
Thank you, Mr. Chair. I appreciate you saying that you can't do the standard deviation. That makes me feel not so stupid because you're really smart. But who does figure this out? I mean, it's like the PHP doesn't figure it out, right? There's the standard, and then are they told? Is somebody told what the 2 deviations are, or does somebody have to figure that out? This seems like really complicated to me.
Senator Sorry.
Thank you for your compliment. I appreciate that. That was very kind. So what I have been told, and I have not looked at this independently, so I'm going to mea culpa that, is that there is a median point for billing for a particular procedure, right? And that you can make the determination of what the deviation is internally within the PHP. I've not seen that in practice yet, so I can't speak to it precisely. But in some discussions that we've had with some of the stakeholders, they seem to believe that this is something that can be ascertained fairly easily.
Follow up, Mr. Chair. Yeah, thank you. And the $250,000 number, that's extraordinarily high. You can get in and out of a hospital for a whole lot less than that, but still have a pretty detailed itemized bill and that you might want to see. So how did we arrive at that number, and is it possible to lower it?
Senator.
It's certainly possible to lower it. Thank you, Mr. Chair. It's certainly possible to lower it. I think this is a reduction in the current rate as it is. And I don't have the current statute in front of me, but I believe the threshold is already significantly higher.
Another follow-up?
Yes, thank you. I mean, again, I would think, even if you just go, if you're in the ER or even just one night in the hospital, that's going to be, thousands of dollars, maybe $20,000. I would want to know what the items are on that. I mean, are people in the audience going to freak out if I say, can we lower that to $5,000 or $10,000?
Sorry.
I'm open to anything, any suggestion about this. I would have no objection to that at all. I agree, and I think transparency is a big part of this. I think the Senate Healthcare Committee last session in the long session passed a lot of bills with respect to pricing transparency. This is a similar thing. This is specific to Medicaid though, because we are seeing billion-dollar rebase costs. We need to know what it is that we're paying for. We need to know what it is that our enrolled beneficiaries are getting. I think transparency helps us on the taxpayers. It also helps us on the outcome side to understand exactly what it is that's making a difference in providing a healthier, more successful outcome for the patient. So, anything we can do to lower that threshold and to provide greater transparency is a good result. This is a first stab at it. I do think the 2 standard deviation captures a lot of claims. Some of the concerns we've heard about this is the administrative burden on hospital systems and their billing departments. Are we putting something on them that's going to generate more cost than there is benefit? I don't know. I think that's a fair question to ask, but this is a good first step in capturing a broad swath of that.
Co-Chair Galen.
Thank you, Mr. Chairman. I just want to add a comment that this bill applies to the prepaid health plans, or the PHPs, and those are the companies that administer the standard plans under Medicaid. So this bill does not apply, to general regular insurance or uninsured patients or anything like that. As Senator Sari said, there are, for uninsured patients and self-pay patients, they have different rights to get their itemized bills. I think the $250,000 is the current law, and so the intent is that the DHHS would not prohibit the PHPs from getting those itemized bills. And so we understand from talking to the PHPs that in some cases they've had challenges in getting access to those bills that are maybe less than $250,000, as you said. But as you can imagine, the volume of bills that would capture, if we said 5,000, would just be incredible. And so this is an attempt to really drill down on the what's the problem. It's those outliers. It's not 5%, 10% more or less. It's the bills that are really in the extreme. So this will help the PHPs to capture those and to examine those.
Thank you. Senator Adcock.
Thank you, Mr. Chairman, and thank you, Senator Sari. Following up on the same section that Senator Mayfield brought up about the outlier claims. First of all, I think we need some experience in this area to see whether it might need to be or want to be lower than 250,000. But my two questions are, since there's no standard definition for Medicaid, there is for Medicare, but not for Medicaid, for an outlier claim, and there's no definition of outlier in the bill, why use that term at all when you're only giving two examples of when the PHP can require those itemized bills, when it's over 250K or when it's more than 2 standard deviations above the median? So that would just be my question as a clarifying thing. And then I have a follow-up question after that.
Senator Sari.
And first, just to address something that Senator Gates said, thank you. I couldn't read my own handwriting with the 750 versus 250, but she's correct about that, and I apologize if that caused some confusion. But yes, there is no definition for outlier claim. I mean, and that's there's a judgment, a subjective element to that. Of course, the PHPs are charged with managing that care. They're going to be able to recognize what are outliers when they see it. I think there's a famous Supreme Court case trying to define something that's undefinable. It's tough to define, but you know it when you see it. The 2 standard deviations off the median is the hard mark on this as to what is something that they can't seek information on, and I think that's your that's your hard line in this particular.
So
follow up.
Thank you. So follow up is, by virtue of that, of section 1B1, you're saying this is how we're kind of de facto defining outlier.
Senator?
Those two things.
That would be what I would look to. Yes.
Follow up. Thank you. So is the median claim amount PHP specific, or is there a standard claim amount for that particular ICD-10? That's the diagnostic code, or the CPT, which is the code you would use for labs or other kinds of procedures.
Senator Sari.
I understand that there is a standard amount, per code. I defer to staff though if there's something PHP specific, just to make sure that there's okay. So yes.
Jennifer, Jason, anybody? In particular? Okay. We'll try to get something back to you on that.
Thanks very much.
Senator Heiss.
Thank you, Mr. Chairman. First, maybe just some comments on this. We should generate 2 standard deviations off the mean. Should show we'll get about 2.5% of claims will be flagged by that, assuming it's a fairly normal distribution. That's what you would expect. And coming in, and it will allow us to see what this process is, and if we're seeing errors or we're seeing excessive billings in those numbers, then we come back in others. But I think this was kind of set at what we can put the dive into, what we can put an analysis on. It's not uncommon in everything we've done in healthcare to look at the high cost patients first. That's the most return on your dollar amount. But ultimately, this is something that needs to be able to be evaluated on all claims submitted to Medicaid, and how they're, whether particular hospitals have found ways to change codes and do other things for the simple fact of maximizing billing versus the amount for what they're actually performing. One thing that we've not seen emerge that I think would address a lot of this, that we really hoped for in Medicaid reform, was to begin to see the abundance of bundled payments, where that if you go in for a particular procedure, we would have a contract in place that this is the amount you receive for this procedure, and really get away from this fee-for-service thing, and we would actually put providers at risk for overrunning these costs. And I really hope that we continue to move in that direction, and hopefully one day we'll see almost all payments from the PHPs being these bundled kind of payments. But as long as we're running this fee-for-service and those kind of things, and I suspect while we've not seen bundle payments, if you can make this fee-for-service kind of thing that much more profitable, you might not want to jump systems just yet. But I commend what you're doing in this. I hope that we really have got to get to a position where the managed care companies have some skin in the game and a better ability to control cost, and keeping them from being able to see even the itemized billing of services they're providing just doesn't make a whole lot of sense if they're going to be in that management of cost.
Senator Adcock.
Thank you very much. Thank you, Senator Heiss. I did want to point out one clarification. It's 2 standard deviations from the median, not the mean. The mean's the average, and the median is half above, half below, so it'd make a big difference, wouldn't it?
Senator Heiss.
Okay. Yeah. And the other thing is about bundle payments. So think back to 1983 when some of you weren't even alive, and the federal government, CMS, came out with DRGs, bundle payments. And it's so good in theory, and it often works, except for when you have not every patient that goes in to have their gallbladder out is a healthy 23-year-old, right? Some of them are 60-year-olds with bad hearts and high blood pressure and kidney failure. So it's really tough or you have to make some allowances for the fact that not everybody comes in and it takes exactly that amount to take care of their problems. So I think we just have to keep that in mind going forward. I don't disagree at all about the philosophy of bundle payments. It makes a lot of sense to get that, to pay for value and outcome and not just every time you do something. But I think we should have a little caution about that.
Any other questions from the committee? Senator Mayfield.
Thank you, Mr. Chair. I note that in both sections of this bill, what we're actually doing is it says the department shall not prohibit PHPs from doing any of the following. Was the department prohibiting PHPs from doing these things? Are we worried? What are we worried about here? Everybody seems to think it's a good bill, so I guess I think it's a good bill, but what are we worried about the department prohibiting these things? Do they prohibit them now?
Thank you, Mr. Chair. So it's my understanding, in part of some global issues that we hear about the managed care program is that the coding or the codes are not standardized currently, and that is that there's some frustrations with what the department is allowing, is not allowing. I'll let the department speak to that, but this draws a hard line in the sand as to what is going to happen going forward. And then same thing with site of service, with the lab services as well. I think that's a big part with controlling costs, obviously looking for lower cost alternatives, and telling the managed care plans that, just say the program is continuing to cost more every year. And I think somebody asked a question the other day in a different place, and the question was why, right? Why is it doing it? We see as DHHS calls it, the Jello chart of seeing the different colors of what's driving this cost. Information is helpful. It's going to be more important than ever. This is ultimately going to allow us to have more information as to what's driving this cost increase. And it's also going to make us be in a better position to make sure that every stakeholder in the Medicaid game, everybody, providers, hospitals, PHPs, they're going to have to be at the table to have a conversation about how this cost is better controlled. It's across the board, and I just want to be very clear about that, hearing some things that we've talked about already. Everybody has a part in this, and everybody needs to play a part in making sure this program continues to be financially viable going forward, and this is part of that formula.
Seeing no other questions, would anyone in the audience like to make any comments? All right, seeing none, we're going to move on to the next bill, but before I do that, we have a group of folks I want to recognize that I met with earlier. We have a group of future radiologists that are here from Johnston County Community College. Their instructor is sitting in the middle, and I think they all acted like they really liked him when I talked to him, and the head of the department. So all of you, raise your hands so everyone can see who you are. They're kind of dressed alike, but you might want to meet them. They might be doing an x-ray or something on you in the future. So we're glad to have you all here, and did want to you all are very enthusiastic about what you're doing. At this time, I'm going to turn the podium over to Co-Chair Gailey, and I'll be running the next bill.
Thank you, Mr. Chair.
while Senator Bergen gets situated, I'll just mention that they're from Randolph County, if you didn't notice. So it's good to have you on. So Senator Bergen, you're recognized when you're ready.
Thank you so much. This is another PCS, and it's about facility fees. And right now, the Medicaid, this bill will say that the Medicaid program does not reimburse for facility fees unless the services are provided on the hospital's main campus at a facility that includes an emergency department or at an ambulatory surgery center. We have the definition is included in this. On campus is the main building of a hospital, the physical area immediately adjacent to a hospital's main building, other structures not contiguous to the main building of a hospital that are within 250 yards of the main building, any other area that has been determined to be part of a hospital's campus by the Centers of Medicare and Medicaid Services. And then the definition of a facility fee is any fee charged or billed by the healthcare provider for outpatient service provided in a hospital-based facility that is intended to compensate the healthcare provider for operational expenses of the healthcare provider, separate and distinct from a professional fee, and charged regardless of the mobility through which the healthcare services were provided. And so and then there's a definition of professional fee, any fee charged or billed by provider for hospital or professional Medicaid services in hospital-based facility. And I want to kind of continue the thought that Senator Sari said. We have got to get a hold of cost. You heard in this committee many times and in joint committees about hospital costs and overall healthcare costs in North Carolina. And with a potential $1 billion rebases, and we just passed the bill yesterday for the rebase, the $319 million, this is a step toward trying to address fees and especially facility fees that are charged at facilities that are either been purchased or that are away from the campuses. And I'll be happy to answer any questions.
Thank you. Questions from the committee? Senator Mayfield.
Thank you, Madam Chair. So this bill says that the Department of Health and Human Services, that the Medicaid program shall not reimburse for these facility fees. Does that mean that the hospitals are going to go to the patient to get those fees directly? How do we protect the patient here? I understand we're protecting ourselves in the state program, but how do we protect the patient?
Well, I'm not going to say that they won't try to bill them. I think that it'll be for naught, but I have not talked to the individual hospitals about what they're going to do. I think most of them know that that's not going to be collectible. And with the Medicaid write-off that they already do, I think that it will take care of itself. But I do think that we probably need to continue. This is the first of a number of items that we're going to be dealing with about cost.
We recognize staff to further that explanation.
Thank you, Chairwoman Gailey. Jennifer Hillman, Legislative Analysis Division. Federal Medicaid law does prohibit providers who accept a patient as a Medicaid patient from passing on any of the charges to the patient.
Thank you, Jim.
Follow up? Other questions or comments? Nobody has any questions or comments on facility fees? Okay.
Very good.
All right, well, you did such a good job, Senator Bergen. This was a notice for discussion only, so we'll have a chance to revisit it tomorrow. So thank you. I guess, well, I'll let you.
Okay. I want to thank everyone for coming. Remember, go out the side doors, not the back door, even though I think we're so far ahead of getting of them coming in that we're in good shape, but I still do what the Sergeant at Arms suggested we do. We are adjourned.